Good day, students. I'm Dr. Williams-Persad, and today we're going to discuss antiretroviral drugs. They're used to treat HIV infections, and HIV is an RNA retrovirus, as you know. There are two types of HIV. There's HIV-1, which is the principal organism that causes acquired immune deficiency syndrome, or AIDS, or disease. The HIV-2 works in a similar manner, except it's less virulent. The interactions of HIV with the host immune cell is a complex one, and we'll look at it in a little while. And it involves mainly cytotoxic T lymphocytes, CD8 T cells, and CD4 helper T lymphocytes. We'll talk about the CD4 cell counts when doing an HIV diagnosis. Other immune cells, such as macrophages, dendritic cells, and natural killer cells, play a role in fighting against HIV infection. There are also antibodies that are produced by the host to various HIV components. But it is the action of the cytotoxic T lymphocytes and the CD4 cells that are the initial prevention or defense for the host against an HIV spread. So, how does the HIV virus infect a CD4 helper T cell? There are 10 steps. And if we look at this diagram while I explain, you'll see the stages. The virus uses the CD4 co-receptor and the chemokine receptors, CCR5 and CXC4, and binds to the site to facilitate entry. So it binds and fuses to the host cell where it enters. Once entered, it becomes incorporated with host DNA. When transcription occurs, the T cell is activated, and then transcription factor, nuclear factor kappa B, initiates transcription of both the host cell and the provirus DNA. The viral protease cleaves viral polypeptides, and they've cleaved them into enzymes and proteases and proteins, structural proteins. These enzymes include integrase, reverse transcriptase, and protease. And the structural proteins are what helps to form the new virion. Then assembly occurs, and when assembly occurs, the new active virus is released for a whole new round of infections or the cycle to occur in other CD4 cells. So, looking at this diagram, the site of action of antiretroviral drugs are shown here in the white boxes, and these include the chemokine receptor antagonists. These are the chemokine CCR5 co-receptor antagonists, the fusion entry inhibitors, and they are inhibitors of viral fusion, right? The reverse transcriptase inhibitors and the inhibitors of viral integrase, as well as the protease inhibitors and the inhibitors of viral shedding. So this is how we'll discuss the different subclasses of antiretroviral drugs and how they work. So I want to look at a case for us to think about while we discuss each of these classes of drugs. So we have a 35-year-old HIV positive female with a hepatitis flare-up who presents to the clinic. Now sometimes a co-infection is what brings that patient back to the hospital. This patient is antiretroviral treatment naive, so she didn't take treatment when she was first diagnosed 2 years ago. She has a steady decline of the CD4 cell count with rising levels of the HIV viremia since her diagnosis 2 years ago. Today she presents with esophageal oropharyngeal candidiasis, and that's what brought her here. So, what we want to be able to do is to understand the treatment guidelines for this patient, explore the available antiretrovirals and the different classes of them, understand the mechanism of action of each class, and, well, suggest the course of action, what is the initiation therapy, and also I want you to note that single drug treatment may not help these patients as effectively as a multi drug regimen, which is what is used in the treatment of HIV. Multi drug treatments, combination treatment. And with these combination treatments, there can be changes in the drug bioavailability due to drug drug interactions, drug toxicity, or toxicity to the body of either one of the agents or a combination of the agents, such as liver function, elevation of liver function, elevation of enzymes, liver enzymes such as alanine aminotransferases to indicate liver toxicity and other organ toxicity. So these are some of the things that we'll monitor in a patient who needs to be treated with antiretroviral agents. So according to the World Health Organization, antiretroviral initiation should be given to anyone who was diagnosed with HIV at any CD4 cell count, right? So the daily oral PrEP, which is the pre-exposure prophylaxis, is recommended as a preventative choice for people at substantial risk. So persons in healthcare who have to take care of HIV patients and so on. There's also PEP treatment, which you might hear about when you reach into your clinical years, and these include this includes the post-exposure preparation that would be given to patients who, after they may have had a needle stick right after that incident. Also, I want you to be aware of the Center for Disease Control guidelines. They have quite an comprehensive document on pre-exposure prophylaxis for the prevention of HIV infection in the United States, and it was updated in 2021. I have here, but there may be a newer, an updated version for 2023 if it's not out yet. I also want you to pay attention to how the population spread of HIV or acquiring HIV might be might be tabulated or presented in a diagram. So you have the general population, persons in high prevalence groups, then there are persons who are need PrEP, and then there are those who need to be treated for HIV. So that's just a simple picture of what we are looking at or dealing with. So according to the following publications of the CDC, the HIV.gov, those pages on the side there, they issued guidelines for antiretroviral treatment, especially to treatment naive patients. And this generally consists of two nucleoside reverse transcriptase inhibitors, NRTIs, in combination with either one of the three classes, an integrase strand transfer inhibitor, INSTI, or non-nucleoside reverse transcriptase inhibitor, an NNRTI, or a protease inhibitor, together with an enhancer or booster agent such as Combixtat or ritonavir. And we'll discuss these drugs in more detail as we go along. But I want you to remember this cocktail or this recipe, two NRTIs with either one of the other agents. And this guideline was prepared for persons with the following conditions: HIV with co-infections, um, adolescents with HIV, women with HIV, pregnancy and HIV, drug-drug interactions if they have they're taking medication for that may interact with HIV treatment, or combinations that may not that may not be optimal for their condition, especially within the regime and together with other agents, or liver function, as I said, and renal function. So let's go back to our case. So, in order to treat this patient, we need to do a few investigations. And I mentioned before liver function tests. So, we have to assess her. Renal and liver function tests would be done. She has a hepatitis B flare up, so we need to screen her or to look at quantify the HBV DNA levels and also screen her for other hepatitis infections such as A and C. Because she's a female and bone marrow density may be affected, a bone mineral density test would be done. She is also of childbearing age, so pregnancy should be ruled out. So, in this case, we need to counsel the patient about the new treatment that they're going to receive. And the treatment that you would want to you may choose to start her on would be the two nucleoside reverse transcriptase inhibitors and one um, integrase strand inhibitor with maybe a booster. I have efavirenz, which is an NNRTI, and then there's a note for risk on pregnancy. This is to remind us that she's of childbearing age, and once pregnancy is ruled out, efavirenz NNRTI is actually one of the more preferred NNRTIs in pregnancy and for children, for prep, for a lot of things. So when we look at the mechanism of action of NNRTIs, we'll see efavirenz again. Also, I want you to note that it is metabolized by cytochrome 3A4 and 2B6 to its inactive metabolite. So remember, drugs that may be metabolized by this way may be inhibited or enhanced, therefore dose adjustments would need to be monitored for this because the effect may be eliminated or the therapeutic effect would not be achieved. So we need to discuss the mechanism of action of each of these agents and understand the adverse effects that may occur in each group. So in this 1 hour, we're going to look at all of them, and we have the nucleoside reverse transcriptase inhibitors. I don't need you to remember their structure, but I do need you to understand and appreciate that some of them are pyrimidine and purine nucleosides, and the difference being their single and double rings. This will affect their mechanism of action. It will affect their bioavailability. It will affect their activity and their pharmacokinetics. So that's important. M-tricitabine also is a nucleoside analog of cytidine or fluorinated analog of lamivudine, meaning that because it is a cytidine analog, you would see it also in the treatment of some cancers. So it's one of those anti-cancer agents similar to capecitabine or the fluorinated analog similar to lamivudine, which we will see as we go along, which is also an NRTI in the group. So how does it work? NRTIs need to be triphosphorylated, but we'll look at the triphosphorylation at the end because I need you to remember those enzymes. Once they are phosphorylated, NRTIs act by competitive inhibition of HIV reverse transcriptase. And like all viruses, mutations can occur to develop resistance against these drugs. And this is one of the point mutations, M184V mutations. And this is observed throughout their classes. All NRTIs are associated with mitochondrial toxicity, which may manifest as peripheral neuropathy, one of the adverse effects that we will observe. Pancreatitis, lipoatrophy, or hepatic steatosis may be observed. Also, you need to halt treatment when liver enzymes are too high, ALT, progressively developing hepatomegaly, or metabolic acidosis of a known cause is happening in these patients if they are taking an NRTI. There are less common adverse effects such as lactic acidosis. When it occurs, it might be fatal. So that's a general overview of all the agents of all the NRTIs. But when we look a little closer at each agent, which I don't want you to confuse yourself with, I want you to remember the agents in this group. So we have the abacavir being the first one. It's metabolized by alcohol dehydrogenase and glucuronidation. The adverse effects associated with it are rarely hypersensitivity reactions, mostly seen in European populations. And therefore, in these populations, you'd want to do the HLA-B5701 screening test, or this is the test associated with the HLA-B5701 allele, to rule out their chances of suffering that fatal hypersensitivity there that you see in the diagram. Didanosine is activated by, well, activated too during its phosphorylation, its triphosphorylation, to dideoxyadenosine triphosphate, DD-ATP. And that's something important to know because it's a double DD-ATP um, uh, derivative that makes it active to elicit its action against HIV. Didanosine causes dose-dependent pancreatitis, so you avoid giving it with zalcetabine, stavudine, and hydroxyurea, right? So what happens with serum levels when given together with allopurinol, ganciclovir, and tenofovir? Didanosine levels increase. They decrease if atazanavir, ritonavir, dalveredine, and methadone are used together with it. And this may trigger off a condition if methadone is being used, methadone, how you say, methadone withdrawal syndrome might occur. And I'll leave that for you to read about some more, read up on some more, because that's not too important right now. But what I want you to recall is that serum levels are affected by the use of these agents together with it. And didanosine causes decreased absorption of other agents such as fluoroquinolones, itraconazole, and indinavir. Therefore, the point to take home here, these agents, if they must be given in a regime to treat a patient with HIV, staggering the dose would be necessary. M-tricitabine, we know is the fluorinated analog of lamivudine, and we'll talk about lamivudine in a little while. It's one of those anti-cancer agents. It's safe in use of pregnancy, and it is one of the agents used pre-exposure prophylaxis treatment to treat HIV and used in the treatment of hepatitis B virus. So we have a patient with a flare-up, and this might be one of the agents that we may choose. Adverse effects on the other side of amtricitamine include hyperpigmentation of the palms and soles and other CNS effects, but this is the most striking one. It's contraindicated with metronidazole or disulfiram, so giving it in patients who use that is avoided, should be avoided, and renal and hepatic failure patients also. Again, resistance is associated with the use of this agent with that point mutation. Also, abrupt cessation may exacerbate hepatitis B virus. So those patients who have resistant strains of HIV-1 to zidovudine and stavudine, the lamivudine may be a suitable substitute. It is also active against hepatitis B virus. So weaning a patient off this agent would be recommended to avoid HBV flare-ups. Drug interactions with trimethoprim sulfamethoxazole could occur, and this causes an increase in lamivudine concentration. Lamivudine treatment is safe for chronic hepatitis B infected patients who are pregnant or mothers. It's one of the pregnancy safe choices with HBV. Adverse effects are CNS in nature, gastrointestinal discomfort with the oral dose, and it is recommended that emtricitabine or zalcetabine not be co-administered since they compete for phosphorylation. Recommended for pregnant women. I mentioned that before. Stavudine, the thymidine analog, is not food dependent. Serum half-life is about 1 hours, but 1 hour, 1.1 hours, but the intracellular half-life goes up to 3 to up to about 3.5 hours. So it's also eliminated through the glomerular filtration and tubular secretion. Important for you to note toxicity as dose related and peripheral neuropathy may occur, especially if given together with agents such as didanosine or vincristine or isoniazid or ribavirin. Pancreatitis and arthralgia, as we mentioned before, with some, well, pancreatitis for the whole class of drugs. Arthralgia due to lactic acidosis with hepatic steatosis. Lipodystrophy may appear more frequently in patients receiving stavudine than those receiving other agents. So this is important to note. Lactic acidosis and pancreatitis when co-administered with didanosine is something to look out for. Other rare effects include the neuromuscular weakness. Zidovudine may reduce the phosphorylation of stavudine, and these two drugs should not be given together. Let's move on now to the tenofovir. So there's tenofovir, disproxil, and it is an acyl nucleoside phosphate, an analog of adenosine with activity against hepatitis B and HIV. It competitively inhibits the HIV reverse transcriptase and causes the chain termination after the incorporation of into the DNA. However, only 2 instead of 3 intracellular phosphorylations are required for activation of tenofovir disproxyl fumarate to inhibit DNA synthesis. This disproxyl fumarate is water soluble. Oral bioavailability increases with high fatty foods. Serum half-life is about 12 to 17 hours, and the elimination takes place through the kidneys. Therefore, dose adjustments are required in patients with renal insufficiency. A combination of fumarate disproxyl, tenofovir disproxyl fumarate, and emtricitabine is the only FDA approved formulation for pre-exposure prophylaxis to reduce HIV acquisition in high-risk persons. So let me just repeat that. Tenofovir disproxyl fumarate and emtricitabine is the only FDA approved formulation for PrEP to reduce HIV acquisition in high-risk patients, and tenofovir is also approved for the treatment of patients with hepatitis B infections in a single dose. You need to monitor this for bone mineral density though, and also, especially, not and also, but especially with long-term use. The alafenamide phosphate, it is associated with less renal and bone toxicity. It's better tolerated and it's rare. It causes rare GIT or headache. So it has a better toxicity profile than the disproxyl fumarate. Because maybe of the low plasma levels and the higher intracellular concentrations of the tenofovir analog or metabolite, which is the tenofovir diphosphate. Right? So tenofovir alafenamide, it is a substrate for P-glycoprotein also, and levels of tenofovir can be affected by inhibitors or inducers of P-glycoproteins. Ritonavir and combixtat can increase plasma concentration of this drug, while darunavir, for example, can reduce plasma concentration. So, tenofovir alafenamide together with ritonavir and combixtat, which is another class of antiretrovirals, can increase plasma concentrations, while the other class, the darunavir, reduces plasma concentration. Of course, resistance is associated with a different type of mutation, and it's usually used in a single dose against HIV and hepatitis infections. Zidovudine is a deoxythymidine analog that is well absorbed and distributed to most body tissues and fluids, including the CSF. So, absorption and its half life is about 3 to 4 hours. So, a twice daily dose of zidovudine is required. Renal excretion following glucuronidation and in the liver occurs. Activation by enzymatic phosphorylation to the triphosphate, as we will see in a little while, the steps that I need you to remember. It competes with other agents that NRTIs that need to be triphosphorylated. It is pregnancy safe, but unlike the other agents in this class, it is associated with a lot more mutations to give rise to um, resistance against this drug. Adverse effects include myelosuppression, GIT, headaches, and insomnia, lipodystrophy when co-administered with thymidine analogs. It interacts by induction or inhibition of glucuronidation with other agents such as atovaquone, atovaquone, lopinavir, ritonavir, probenecid, or valproic acid. And together, it decreases phenytoin levels. So that's some notes about this zidovidine's adverse effects and drug interactions. So the drug activation process of these agents includes triphosphorylation, as I mentioned. I don't need you to know how to draw these diagrams, but I need you to know the enzymes that are involved. Thymidine kinase takes the drug to its monophosphate. Thymidylate kinase converts the monophosphate to the diphosphate. And nucleotide diphosphate kinase converts the diphosphate to the triphosphate. And this is important for you to recall about NRTIs. So let's move on to the NNRTIs. These include delavirdine, efavirenz, etravirine, nevirapine, and rilpivirine. A little bit of a tongue twister, but I need you to remember how to spell these agents and understand that they are NNRTIs. NNRTIs do not require phosphorylation for activation, and they do not compete with nucleoside triphosphates for activity. There is no cross-resistance or tolerance with NRTIs. Resistance from the mutation in a different part, which is called the Pol gene or the DNA polymerase, occurs rapidly if these agents are used in monotherapy. So you're looking out for a different type of mutation, the DNA polymerase or GAG-Pol mutations. So NNRTIs, they are allosteric inhibitors in a non-competitive manner. They bind near the catalytic site of the HIV reverse transcriptase. So They attach to the HIV reverse transcriptase, resulting in allosteric inhibition of RNA and DNA dependent DNA polymerase activity, as you see in the diagram. Binding at this site is an allosteric position, is at an allosteric position. Unlike the NRTIs, these NNRTIs, they don't compete with nucleoside triphosphorylation and they don't require phosphorylation, as I mentioned before. So let's look at each of the agents quickly. All NNRTI agents are substrates of CYP3A4 and can act as an inducer, such as nevirapine, inhibitor, delavirdine, or a mixed inducer inhibitor, etravirine or efavirenz. Therefore, drug-drug interactions should be monitored closely with frequent dose adjustments when needed, and some combinations are contraindicated within this class. Delavirdine has a high oral bioavailability, but its absorption is affected by the presence of H2 blockers and antacids. It causes skin rashes in about 38% of the patients and avoid in pregnancy because it is teratogenic. It is metabolized by the cytochrome 3A4 and 2D6 enzymes and also inhibits these isoforms. So therefore, drug interactions with these agents listed here would occur, either reducing serum levels of delavirdine or increasing serum levels in the presence of concurrent use with these agents. So doravirine, it's a pyridinone doravirine taken without food has an absolute bioavailability with a half-life of 15 hours. It has a unique resistance pathway unlike the other NNRTIs, and some common adverse effects include the headaches, nausea, diarrhea, and rashes. Less CNS and fewer negative effects on the lipid profile observed compared to efavirenz, ritonavir boosted darunavir. So that is something to consider. Also, it is metabolized by the CYP450 pathway. Therefore, drugs that are metabolized by this pathway, CYP3A isoform, would have interactions with doravirine if given together, such as rifampin, rifapentin, efavirenz if given together. St. John's wort also may substantially decrease doravirine's concentration, and it is contraindicated. A dose of doravirine must be increased when administered with rifabutin. So efavirenz, it is the preferred NNRTI. However, since 2015, however, it's now considered an alternative treatment. It's a potent suppressor of the HIV-1 replication. It is indicated in the treatment of HIV positive patients as well as treatment naive patients and in combination with tenofovir diproxyl fumarate and emtricitabine comes in that combination. As I mentioned, since 2015, it was part of the one pill once a day regime, but since then, it's now considered an alternative therapy because of more favorable newer agents in the NNRTI group with better tolerability profiles and less drug-drug interactions, especially with the other class of antiretroviral compared to the other class of antiretroviral agents. Um, the integrase transferase inhibitors, they have a better profile tolerability. So anyway, efavirenz remains extensively prescribed worldwide, especially within resource limited settings or countries, among those pregnant patients, patients desiring pregnancy, and patients with co-infections such as with TB. It is well absorbed with fatty foods and has a long half-life. It also has a narrow therapeutic index. Therefore, monitoring drug metabolism is crucial. Like all the NNRTIs, it is metabolized by cytochrome P450 metabolism. It's also important to note its CNS dysfunction or adverse effects, rashes, and the possibility of increased plasma cholesterol. When co-administered with other agents in the class of NNRTIs, it may be contraindicated with co-administration of elvitigravir, for example, etravirine, which we will look at in a little while, endinavir, itraconazole, and ketoconazole, other agents in different class in other types of drugs, for example. So etravirine was designed to be effective against strains of HIV that had developed resistance to first generation NNRTIs due to mutations of different types. So, due to different types of mutations, so it's used in patients with HIV resistance to other drugs. Again, like all the NNRTIs, it is metabolized by the cytochrome P450 pathway, and adverse effects include similar to the group of similar to the group of NNRTIs: nausea, rashes, increased cholesterol, triglycerides, liver enzymes. It should not be given together with other NNRTIs. Nevirapine combination regime is effective in preventing vertical transmission from mother to child during the onset of labor to the neonate. It's metabolized by CYP3A4. Its adverse effects are consistent with what is seen in a group of drugs, and because of the way it's metabolized, drugs such as cimetidine and macrolide antibiotics may interact with the agent by increasing its serum concentration, or rifampin may reduce its serum concentration. Rilpivirine is used to treat patients who have never received antiretroviral patients yet. It's one of those treatment naive agents, and it's an alternative in pregnancy. Combination, it comes with emtricitabine and tenofovir. It's well absorbed with high fat foods, but proton pump inhibitors may reduce its bioavailability. Its side effects are similar to the NNRTIs. Let's move on to the protease inhibitors. These drugs, during the last stage of HIV growth, they work. So during the growth cycle, the GAG and the GAG-POL gene products, which I mentioned at the beginning of the lecture, are translated into polyproteins, which become immature budding particles. The HIV protease is responsible for cleaving these precursor molecules to produce the final active protein, final structural protein of the active mature virion core. By preventing the post-translational cleavage of the GAG-POL polypeptide, protease inhibitors prevent the processing of viral protein into functional conformations, and this gives rise to immature, non-infective viral particles. So remember the GAG-POL polypeptide. This is where protease inhibitors work. It's on the diagram here to prevent maturity. So protease inhibitors do not need intracellular activation. The, the agents are here listed: atazanavir, darunavir, and we'll look at the major side effects of it. So the major side effects include metabolic effects, such as fat redistribution, as you see in the diagram there, dyslipidemia, hyperglycemia, hypertriglyceridemia, GIT disturbances, paresthesia. These are things associated with protease inhibitors. And drug-drug interactions are due to its pathway of metabolism by the cytochrome 3A4 system. So atazanavir simply is taken with meal. Its absorption is enhanced through acidic medium. It penetrates through the cerebrospinal fluid and seminal fluid. It is pregnancy safe, and especially when boosted with ritonavir. It's contraindicated with the following agents below. other NNRTIs as well as proton pump inhibitors. Darunavir is co-administered with ritonavir. It's a sulfonamide containing compound, so therefore persons with sulfur allergies may be contraindicated, may suffer allergies. Adverse effects are consistent with this class of drugs. Then we have the fosamprenavir. It's a prodrug of amprenavir. It contains the polypropylene glycol, and you can tell me why in class, why polypropylene glycol is important for us to know. It has a sulfonamide moiety, and therefore we know that allergies to sulfonamides or sulfur would be contraindicated in our patients. When it's combined with ritonavir, a lower dose may be used. Co-administered at low dose with ritonavir. Avoid high in meals in avoid meals high in fat because it reduces the absorption of this agent. Fosamprenavir is not safe to children, pregnant women, patients with renal or heart failure, or patients on metronidazole or disulfiram. It's contraindicated with vitamins E. Also, lopinavir, ritonavir, they reduce amprenavir's level. So this is important to note. Indinavir, its absorption in acidic medium is preferred on an empty stomach with which is low in fat and protein, or diet which is low in fat and protein. It's given with a low dose of ritonavir like the other protease inhibitors, and one of the unique adverse effects is associated with hyperbilirubinemia, nephrolesthesis compared to the other protease inhibitors. Ritonavir is that booster protease inhibitor. It increases the absorption of other PIs. It increases bioavailabilities of other agents, antiretroviral agents. It's recommended in pregnancy. It increases the digoxin toxicity, which is something important for you to note, and also decreases theophylline effects. It is associated with QT prolongation and when if given with saquinavir, so avoid that. Lopinavir is co-administered with ritonavir again. It is useful in co-infections with hepatitis B or C and in HIV settings. It's also useful with TB co-infections. According to the World Health TB treatment guidelines, review of and key considerations were made with respect to TB and HIV. So one of the things that is a key contraindicated drug combination is rifampicin, not rifabutin, rifampicin and protease inhibitors. They are contraindicated. So when a person is co-infected with TB and receiving HIV antiretroviral treatment with a boosted protease inhibitor like lopinavir, rifabutin need to be substituted with the rifampicin. If rifabutin is not available, only a lopinavir-ritonavir combination can be concomitantly used with an HIV patient for the complete duration of treatment of their TB condition. So, ritonavir, lopinavir combination during the course of the TB treatment is required, but a boosted dose of ritonavir or increased dose of ritonavir to supplement for that rifabutin the lack of the rifabutin availability. So the dose of ritonavir is increased or doubled that of the standard lopinavir ritonavir combination. So we know that ritonavir and lopinavir comes in a combination. When there's a TB patient in the absence of rifabutin, uh, and to substitute with rifampicin, you use a double dose of the ritonavir, a higher dose of the ritonavir. Nelfinavir, drug-drug interactions, as we mentioned before, with increased serum levels of efavirenz, decreased serum levels of saquinavir or proton pump inhibitors such as omeprazole. Saquinavir, a once daily dose in combination with low dose ritonavir. It should be monitored for QT prolongation or Torsades de Pons risk when given with this ritonavir. It undergoes first pass metabolism, and the metabolite acts as a substrate and inhibitor to cytochrome 3A4. So also increased absorption with fatty meals is good for absorption of saquinavir. So these are things to monitor the dose of the agent given to the patient at that time. And the side effects are consistent with the class of protease inhibitors. Tipranavir contains a sulfonamide moiety. As a result, sulfur allergies may ensue to those who are susceptible. Treatment experience and resistance to other PIs. So, tipranavir is one of those agents that are chosen after a protease inhibitor does not work as a substitute, and it's used in patients who have received treatments for antiretroviral agent therapy before. It's used together with ritonavir, and one of the striking side effects that is different from the others in the class is that skin peeling or desquamation is one of the side effects observed, as well as urticarial and maculopapular rashes in women, as you see in the diagram here. So now for the fusion inhibitors. This class of drugs interferes with the binding and fusion and entry of the HIV virion to the CD4 cell. Enfuvirtide binds to the viral protein GP41. So it interferes with the cellular membrane, right? While the other agent, which is the CCR5 receptor antagonist, which can be seen here, but we'll talk about it again in the next slide. It is considered a CCR5 receptor antagonist, which is Maraviroc. It interferes with the entry, right? Patients with resistant strains of HIV may prefer this treatment to be more effective. This treatment may be more effective in patients that have resistant strains to other classes of antiretroviral drugs. Unfortunately, resistance due to GP41 mutations will not it will not be effective. There's no cross resistance of enfuvirtide with other antiretroviral drugs. Adverse effects are mild to moderate, painful erythematosus, nodules at the injection site. CNS effects are observed, or they should monitor for, and drug interactions are limited. So now for Maraviroc. It targets the CCR5 co-receptor in the HIV-1 type of virus, but not in the HIV-2. So CXCR4, it cannot bind to it. Therefore, you need to do a test before giving Maraviroc to determine viral tropism. If it is mixed, it would not be as effective. So use only in HIV strains that use CCR5 extensively to gain host access. Resistance would be due to a mutation in GP120 or the V3 loop. No cross resistance is observed across the classes of antiretroviral drugs. So if there's emergent C6CR4 viral types, treatment failure will occur. The adverse effects associated with Maraviroc include increased URTIs, urinary tract infections, coughing, muscle pain, and joint pain, and diarrhea. So for the integrase strand transfer inhibitor, these are three agents: dolutegravir, raltegravir, and elvitegravir. So they bind to the HIV integrase and blocks replication. It's well tolerated, but some of the adverse effects occur, such as headaches, GI effects. It's in co-administration with efavirenz. Use a booster such as ritonavir to reduce side effects. It's metabolized by glucuronidation as well as cytochrome 3A for metabolism. These agents are quite similar and unique. So dolutegravir is active against HIV resistance to raltegravir and elvitegravir. So dolutegravir is used has activity when there's resistance in those agents. It interacts with antacids, laxatives, or drugs that contain sulfates, iron, calcium supplements, or buffered medicines. Some drug interactions are as follows, and their adverse effects include insomnia, hypersensitivity. So you discontinue when dolutegravir hypersensitivity occurs. Raltegravir, it's usually used in treatment naive patients as well as treatment experienced patients. It's well tolerated. However, increased creatine kinase with muscle pain and rhabdomyolysis may occur. CNS effects and hypersensitivity is observed with raltegravir. Finally, elvitegravir, there is high cross resistance associated with across the group of integrase strand transfer inhibitors, uh, that is raltegravir and dolutegravir. Elvitegravir is usually taken with food to increase its bioavailability. Back to the cross resistance, it is due mainly to a G140 and Q148 substitution in the viral life cycle. So it's a where there's a change in the DNA makeup, right? So that's why there's cross resistance of these agents with elvitegravir. Another important or more important point to note about elvitegravir is that you avoid with renal compromised patients, especially those with clearance less than 70, and you definitely want to not use it if it's less than 50 mils per minute. Elvitegravir usually comes in combination with emtricitabine and tenofovir. So this brings us to the end of antiretroviral agents and all the different classes and how they may be combined. Remember, the treatment goals are: the cost reason for antiretroviral treatment is to decrease morbidity and mortality, improve quality of life, and preserve the immune function. Also, to prevent further transmission through maximum suppression of HIV replication. The standard of care using multi-drug regimes, highly active antiretroviral therapy is recommended. There are new FDA-approved combinations to avoid drug-drug interactions, adverse effects, to enhance drug efficiency and treatment, and to avoid multiple use and to improve compliance. So there are some preparations that are in combination to reduce the number of medications to be taken and the frequency. So here are some of the multi-class combinations. So we have efavirenz, emtricitabine, tenofovir, the emtricitabine, relpivirine and tenofovir, the atazanavir and combistat. So there are a few combinations out there, and with scientific research, these agents are optimized, newer agents are developed to have a better um, tolerance profile, a better therapeutic profile, and lower side effects associated with it. So if you have any questions, we can entertain them in class or you can email me for further questions.